Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good morning to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
As a reminder before we begin, if you have a question for Dr. Mingle, please send it to us via email at hello@minglehealth.com or in a YouTube comment or in a LinkedIn comment. So, are you ready, Dr. Mingle?
Bring it on, Kyle.
Okay, our first question for you today is from John, and John asks, we are a community health system and have been using ECQMs through our EHR and reliably getting a small positive MIPS adjustment. That is, until this most recent reporting period, when we ended up in the penalty range. How do you recommend we get ourselves back to a positive number again?
Great question, John. I think you're in good company. A lot of good organizations are finding themselves with negative MIPS adjustments. MIPS has been ramping up since its onset in 2017, gradually reducing the opportunity for extra or bonus points and bringing all of the performance categories up to their most demanding levels. Now, a lot of that phase-in dynamic was actually hidden during the COVID years when there was COVID forgiveness built into 4 years of submissions. That phase-in continued invisibly behind the scenes. And we didn't get a pass on that when it came back. When MIPS returned, it came back at its full ramped up dynamics when the pandemic officially ended. Now, 2024 was the first full year, the first full performance year without substantial pandemic forgiveness. 2026 will be the first year that we experience the full weight of post-pandemic adjustments to our Medicare payments. Now, the first point to realize is that no matter how well you do, the system is designed to give roughly half of the participants a negative adjustment and give the money retained from those negative adjustments to the providers in the positive adjustment range. There's a competitive nature to this. Only half of providers typically will be getting a negative adjustment and half a positive adjustment. Now, there are some oddities in the math of the grading curve that render this not completely true, but conceptually, that is how it's intended to work. Half of us will experience a negative adjustment that will fund the positive adjustments experienced by the other half. Now, you not only have to do well on all four performance categories, you have to be in the upper 50th percentile of performance when compared to your peers. You can't afford to neglect any performance category. Now, perfect MIPS score is 100. Contributing to that 100 points are 4 performance categories. 30 points come from a perfect quality score. 30 points can come from a perfect cost score. 25 points can come from a perfect EHR utilization score. They call that promoting interoperability. And 15 points from a perfect improvement activity score or practice improvement process. There are a lot of special exceptions to these basic rules, but overall, this is how the program works, and mastering your knowledge of the basics should help you push toward a positive adjustment more reliably every year. Now, Medicare has set a target of 75 out of those 100 possible points to be the performance threshold. It's the score that, at least in one index year, and typically most, was the median score nationwide. Half of submitters are expected to get a score below 75. Half of submitters are expected to get a score above 75. So 75 is what they call the performance threshold, and that defined you're getting a positive or negative adjustment. A total miss in either cost or quality gets you completely out of the running for positive adjustment. 30 points out of 100, you only get 70. You can't hit that 75 points. A total miss in EHR use means you can at best have a neutral adjustment. It leaves you a 75, so you do perfectly on all the uh, other three performance categories. You can be neutral. Practice improvement points should be a solid foundation on which you can build the rest of your submission. Those 15 points won't lose that incentive range for you, but again, they can be a good, solid a foundation that you can afford a little miss on some of the other categories and still make the incentive range.
With that outline in place, Dr. Mingle, let's move on to the first performance category, which is improvement activities. Can you explain how to improve our performance in improvement activities?
Great question. And thanks, Kyle. Yeah, so improvement activities should be a reliable 15 points for you. It's not hard to get full credit for this. The most important cost of the IA activity is opportunity cost. Your providers need to put in the requisite time and effort. There can be other costs involved depending on what the activity is, but the only thing reliable is you have to put in the time and the effort. There should be no reason not to collect 15 points for this category. It's even easier in 2025 than it has been prior. Starting in 2025, all activities have the same weight. A group practice with no special statuses needs just 2 activities, no longer concerned about weight, to get full score. In the past, they needed 2 high weight activities or 4 medium weight activities or some combination. Now it's simpler, just 2 activities, you get a full score. There are a lot of activities to choose from. The key is to find 2 that align reasonably well with your goals in your practice. To get full credit for your improvement activities, half of your provider staff at a minimum must be engaged with each of your 2 projects to get credit. Each project must be active for at least 90 days in the performance year for each provider to be counted. It has to be a continuous 90 days for each provider, for each project, but it does not have to be the same 90 days across all the providers in the group. The list and the specifications for all the available improvement activities are available on the qpp.cms.gov website. And we typically provide assistance for our clients to sort through the voluminous list. The specifications will describe exactly what needs to be done to qualify for the activity and exactly what records need to be kept to prove your involvement and compliance. It does not need to be time consuming, but providers do need to be involved. Particular projects might involve the purchase and implementation of software or equipment, the printing of new forms, the hiring of staff, or training of existing staff to operate the new processes. That'll be particular to the project.
Well, let's move on to the next performance category, which is promoting interoperability. How do we do better in PI?
If you want to score well in MIPS, you can't neglect the promoting interoperability category. There are a number of special circumstances that render this performance category irrelevant. If so, the points will be redistributed to the remaining performance categories, making each of them that much more important. To earn points in the promoting interoperability category, first you have to be using an EHR. It has to have up-to-date certification as specified by the Office of the National Coordinator of Health IT, called the ONC. And you need to be able to show that you're using it in certain ways. This can have a significant price tag to license the software, to acquire and maintain the necessary hardware, to train users and maintain skills, and to implement associated functions. Those functional requirements include: you have to be electronically prescribing with the system. You have to query your state's prescription drug monitoring program if you're prescribing any controlled substances. You have to exchange electronic health records with clinical partners, receive them when you're getting referrals, send them when they're making referrals. And it's more about capability than volume of use. You have to show you can do it and that you've done it at least a measurable number of times. there's a few options to make this part of it work. You can do direct exchange between clinical partners. You can use a regional health information exchange, or there's a national program you can sign on to that pushes you in that direction. You have to provide patients access to their health information. Now, most organizations do this with a patient portal. That patient portal might come with your EHR, or it might be an independent add-on. There are expenses related to licensing, implementation, maintenance, and operation. But again, it is a required function in order to get your full points, or any points that, for that matter, for promoting interoperability. You have to exchange data or be in the process of implementing a data exchange with your state immunization registry and with your state health department for mandatory case reporting. Now, and there's also a number of attestations required to pass the promoting interoperability performance category. Attestations about the usage, attestations about lack of restrictions on access, your security precautions and knowledge. Um, uh, Again, most deficiencies in your proof of use result in a 0 score on the entire category. If you don't have at least one prescription, at least one exchange of data, if you're not able to show that, most result with a 0 score on the entire category. Now, there are a number of limited exclusions available for any particular category. They're usually temporary. They have a limited number of years that you can use them. And if you win them, they result in a redistribution of the available points, not a forgiveness of those points.
Great. Well, let's move on to the cost performance category. How do we improve there?
You probably have the least immediate input into the cost category. It counts for 30% of your MIPS score. A loss or forfeiture of all 30 points makes it impossible to be above that 75-point performance threshold to be in the positive incentive range. So it's an important category. The cost profile in your system is deeply rooted in the training of your providers, your local traditions and expectations of your patients and the population, local peer pressure. It's hard to change those factors, even if you know what needs to change. It's hard also to check this category frequently to monitor your results on the fly and the results of your efforts to change this. You can't do it from your own claims. That is your own work. You have to do it from an insurer-sourced comprehensive claims data set. Again, it can be done, but it's hard to do. It's tedious to get it together. It's tedious to get it get agreement from all the insurers that you deal with. Even hard for any one particular. And of course, the most important of those is Medicare. Two techniques quickly come to mind for you to address your cost scoring, even without optimum access to your data. One is the generic, I expect these techniques to reduce healthcare costs. There's a lot of clues to this you can find in the literature. There's a lot of there's ongoing research being done in excess of cost, variation of cost from area to area. You can make some meaningful changes on common sense type of decisions, even if you can't be guided by ready access to the data. The second technique is strategic decisions on cost participation, that is your cost measurement. The one I have in mind is it might be useful to you to choose to do MIPS value pathways, that's MVPs, to select or limit your cost liability. Now, to explain, be guided first by your historic cost scores. Medicare has access to its own comprehensive sets of claims and calculates annually its own cost measures. Most of us have access to those annual measurements through our feedback reports from Medicare, issued annually in usually late summer. Most of us deal with enough volume that we can expect some statistical stability in our cost profiles from year to year. They usually don't move much without deliberate effort on your part or a major local event of some kind, like a COVID pandemic. Now, look at your cost scoring in your feedback reports from CMS for the last few years. It's a good bet you'll see some stability. If your cost profile is naturally comparatively good, half of people, after all, are above average, you can put more of your attention elsewhere. If your profile isn't good, the half that's not above average are below average. Launch an effort to bring your cost profile down, but recognize in the short run it's likely to be more achievable to maximize scores on the other three performance categories. So really put your attention into quality, promoting interoperability, and practice improvement. Now, I've talked more specifically about containing costs in past episodes, and I'll do it again in the future. It's not my intent today to get too far into the weeds on this topic. Be guided by the literature. I particularly like the work behind the Dartmouth Atlas, which deals primarily with unexplained differences in healthcare costs from region to region. And there's a number of other researchers and research organizations that put most of their attention into the delivery of care, not the science of care, and things that go into the cost of care. Also think about participating in MIPS value pathways. In the 2025 performance year, you can still use an MVP to score your entire multi-specialty practice. That option won't be around indefinitely. It had been projected initially to expire for that 2025 performance year, when to use MVPs, you would be required to divide into subgroups. But CMS did not choose to set that restriction for 2025, and it's uncertain at this point when they will. Keep watching it yearly, and until then, you can use an MVP to qualify your whole group. And with a choice of an MVP, you can limit your cost measure, your cost analysis exposure. In traditional MIPS, every practice is evaluated on all cost measures for which they have adequate case minimums. In MVPs, a practice or subgroup using that MVP is only judged on the cost measures included with the MVP. Choose wisely. If you're not going to score well in cost for an MVP that you are eligible to submit, that MVP won't be a good choice for you. You'll not get the good score that you want. Now, stay tuned. I'll dig into this with more specifics and more references in a future episode. In the meantime, I'd be delighted to hear from any of you if you've used an approach that brought your cost profile down for you. I'd love to be able to share that with our other listeners.
And that brings us to our final category today, which is quality. Can you explain how to improve the quality category, Dr. Mingle?
Thanks, Kyle. John's intent with this question was to dig into his approach to quality, and there are a number of tools you can use to go after this. Let's first talk about submission mechanism. John's been using ECQMs. Now, if they're working well for you, it's a solid technique. It can be easy. It can be effortless. You push a button at the end of the year and you get your measures out, and if you can get to the Medicare, you're done. But there are a number of limitations. Pricing for that ECQM engine is a strategic decision of your EHR vendor that can make it either easy or hard. Some EHR vendors charge aggressively for ECQM delivery. Others include it in the core license. An EHR typically has to focus on a one-size-fits-all strategy. They either can't customize per client, or it can be overly difficult to maintain if they have. Now, there are third-party vendors doing ECQM work that's applicable to multiple EHR platforms. We're bringing our own processes live this year. Those independent third parties can be more customizable, but there's still limitations in the rules around ECQM production that don't limit MIPS CQM production, and those can be important differences. If you aren't getting the quality scores you want with ECQMs, consider MIPS CQMs. Now, ECQM failure points include: first, configuration and implementation issues. This is about setting up the system to accept documentation of your clinical work. Sometimes choices that make sense to the users and to your local EHR support team can exclude data from the ECQM engine. I've seen templates for documentation that don't save the data where the ECQM engine can see it or access it. Other templates malfunction by overwriting old data with new, rendering historic analyses, which you often need for your quality assessment, making those analyses unreliable. MIPS-CQMs can give you the flexibility to get the data where it actually lives. It can also give you enough core granular data, that is to be able to drill down to the performance of particular providers, drill down to the existence of particular patients in the data set, and how and why they were judged to be performance met or performance not met. They can give you the data to identify and correct configuration anomalies. MIPS-CQM is a great tool with enough data availability to prepare your practice for effective ECQM use sometime in the future, which is certainly a goal, maybe achievable, maybe not. Training and compliance can be an issue. If you set things up appropriately to feed the needed data to your measurement engine, it still depends on your users to follow the recommended documentation workflows. If they don't, you may not be able to find the data. I found clinicians can find a lot of clever, different ways to document that make more sense to them than what you intended with your quality measurement system. Now, MIPS-CQMs can give you the ability to cast a larger net when looking for data to pick up documentation that lives in more creative locations. Now, measure limitations can be a big issue. There are fewer measures available as ECQMs than as MIPS-CQMs. The ECQM inventory for 2025 is 47. There are 169 MIPS-CQMs to choose from. You only need 6 measures for traditional MIPS. Whether you draw from the ECQM inventory or the MIPS-CQM inventory, there are more measures than you need on either side. Now, many of you know too well, despite all the measure choices, it may be difficult to find 6 that are simultaneously suitable for your specialty and the unique aspects of your practice, or for which you can effectively access the data required for the analysis. Many measures are simply not designed to accommodate structured data easily extracted from EHRs, and many medical record systems and documentation workflows are not adequately designed to collect data in structured format that is easy to extract. Now, if all else is working, the measure could be in topped-out status, which is end of life for a quality measure and is usually accompanied in the early stages by a 7-point cap on the available performance points. It's hard to score above 75 overall and to get into the positive MIPS adjustment range if we're using measures that are capped effectively at 70. Now, of the 47 ECQMs, 21 are not available as MIPS-CQMs. 26 measures go both ways. Every measure has scoring benchmarks to place your score in a competitive array with those of other groups. It's not so important how you perform, but how you perform in comparison to your peers. Benchmarks are set separately by method. The same measure generating the same performance rate in each CQM and MIPS-CQMs might very easily give you a better score in one system than the other. And to further explain topped out, this is where all practices get a near perfect score. Such measures don't really differentiate between practices. Medicare doesn't like them because everyone's getting a high score. Medicare has mapped out a process to gradually retire topped-out measures from use. The first action is to cap the maximum available points at 7 out of 10 for those topped-out measures. Now, topped-out measure status is specific to the submission mechanism. ECQMs and MIPS-CQMs are considered separately. A measure that is topped out and capped at 7 points in one mechanism may not be topped out and capped in both. Now, with fewer measure choices in ECQMs, you may not be able to come up with 6 solid choices without choosing some that are topped out. Measures topped out at 7, that is 70% of a perfect score, detract from your goal of getting that total score above 75. That is the positive adjustment zone. Now, how about improving your score? No measurement system is perfect. It's easy to miss data that would improve your score. You can correct either a MIPS-CQM submission or an ECQM submission. It's easier to correct the MIPS-CQM submission. Correction typically involves a data validation process, or they can be linked together. So let me make a pitch for an annual data validation process. You can use that validation process both to improve your system, to ultimately improve your readiness for ECQMs, and you can use that validation process to improve your score. Medicare requires data validation every year from a random sample of our clients. You may have heard from us if you hit that random selection. You are already engaged in that by invitation. Now, Medicare's interest is seeing the proof that for the patients you call performance met, that you can prove that you have data that makes them so. For your own use, you're more interested in the status of performance not met. We typically can trust that if we find data, it is data, and that's what usually defines performance met. The lack of data usually corresponds with performance not met. Of course, we reverse that in inverse measures, but that's topic of another discussion. Take as an example influenza vaccine. Finding a record of administration means that performance is met. Lacking data may mean that performance is not met, but it might also mean that it was not recorded or is not recorded in the immunization table where I'm looking for it. Now, our process and dashboard gives you access to a list of all patients for all measures with their performance status, including what data went into the status. I suggest you choose between 10 and all of your performance not met instances and cross-check by manually abstracting their medical records. If you find data in the chart that your data extraction missed, you found gold, with which you can improve your scoring immediately and your processes in the long term. In the short run, you can correct your submission. If you're using MIPS-CQMs, you can take that sheet from which that you use to do your data validation, and you could submit it to us as a performance spreadsheet. And we can go through that, see which patients were actually performance met that we considered not met, and switch their statuses because you found the data. If you're doing ECQMs, you can correct the chart through whatever formal record correction method you follow. It's typically an entry made into EHR with an explanation for why it was made, and they sign off by the responsible provider. It's more time consuming, there's more processes involved, but it works. It puts the right data where it's supposed to be, and when you re-pull and resubmit your data, we get the data in the right place and improve your performance marks. In the long run, it'll help you fix your future quality submissions in one of two or a combination of both methods. First, you can identify the providers who are not documenting in a place that you look to get data for analysis. You can provide remedial training. This is how I want you to record vital signs. This is where I want you to record immunizations. And you can improve that record keeping and then improve the performance of your quality measurement in the future. Second, you can expand your extraction queries to include the additional locations you've identified as holding pertinent data. So you don't always have to change your providers. Typically, if your provider's recording textual data you can't find you can't pull with a data extraction, you'll want to change your performance. If they're just putting it into a structured spot you weren't anticipating, you can expand that extraction query.
Excellent question, John. Thank you for sending it in. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. And thanks to everyone for the great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.